Thank you very much indeed, Johannes. Thank you very much in particular to Felix for this invitation to the Langer Symposium. I've been coming for quite a few years, and Peter Langer was an old friend as well, and a great friend, in fact. This is nice after this is around 3 years nearly since the COVID lockdown cancelled all the meetings, so it's quite nice to see all the old faces and friends, but also politically incorrect. I quite enjoyed COVID because I stopped traveling. Now, of course, it's become quite a stressful event with flights, crowded airports, everything. So I'm going to give you a self-expanding valve European Union perspective. And the first thing I need to declare is that I'm from London. So that's completely outside the European Union. So it may be slightly limited perspective. These are my disclosures. And there are, of course, challenges with all of these talks and these sessions, and in particular, the pulmonary valves. But one of the biggest challenges I've faced here is, and I'm looking around, and I've shown some of these photographs previously or taken them, is keeping people's attention. So here I was giving a lecture in this very hall, and Jochen Weil was fast asleep when I was talking. So I quickly took out my iPhone and took a picture. And it wasn't just him. This is Mark Gewillig, who has fallen asleep. And there, it's not a very clear picture. It was Felix fast asleep as well. But the most interesting one was this. And I don't know if he's around or he might still be asleep. But as the session went on, this is how he finished up. And so that's why I'm looking around. I've got my iPhone with me, and just in case any of you are tempted to fall asleep. Nick Haas sometimes does, but I've been watching him, and he's been all right. But my other challenge related to this, the sleeping side, was a few weeks ago, some of you may know that Her Majesty the Queen gave me the honor of knighthood. And so I was really excited. I was thrilled to bits, and I was telling my family. And about a week later, my 9-year-old granddaughter phoned me and said, "You have the most boring voice I've ever heard." And I said, "Why do you say that?" And she says, "I listen to your voice when I want to fall asleep." So that put the meetings and people asleep in a, yeah. So my 9-year-old granddaughter really put it succinctly, and that brought me back to earth. So I think Stefan's given you an excellent presentation of balloon expandable valves. And of course, the abnormalities that we treat are these outflow tract related. And what we've found in practice is that about 30% of cases are the conduit ones where the balloon expandable valves come into play and have a very useful role. But the 70% of patients with native or transannular patched outflow tracts with pulmonary regurgitation as the predominant lesion may not be suitable for these because the valve annulus tends to be big. And so that's where these self-expanding valves will have a role to play. But even for self-expanding pulmonary valves, the anatomy, this was work done by Philipp Bonhoeffer, the anatomy of the outflow tract really has a very important role to play as well in selecting the types of cases that would be useful. So in that classification, the type 3 and type 5 would be the ones that are most likely suitable for balloon expandable valves, and type 2 and type 4 are most likely suitable for the self-expanding valves. And for all these, the type 1, this sort of pyramid shape, is the most unsuitable anatomy for percutaneous valves, whether balloon expandable or self-expanding. Some attempts have been made to implant these, but you do run the risk of complications, and I'll come back to that. Now, all of these self-expanding valves, certainly the venous valve, which I'll focus on, have been selected on the basis of initial MRI assessment. And here are some different anatomies that we've selected for venous valve implantation. And to gain experience, we started off completely from zero experience. We selected the most suitable anatomy and really stuck to the tubular shape. And then gradually, as experience was gained, we expanded the horizon a little bit more. The MRI, of course, depends on how well the imaging is taken and how it's gated. And Stefan's talked about the balloon expandable, which have got the CE mark, the Melody and the Sapien. The VENUSP-VALVE in April of this year has got the CE approval, so that's in business now. The PULSTA valve, there's very limited experience because the CE study is ongoing. Altera in Europe, we have no experience. Harmony in Europe, we have no experience. And so I'm not going to steal any thunder from Matt Gillespie, who's traveled all the way across the pond, and so I don't want to cover that area at all. Then in the future, on the horizon, if you like, the MedZenith PT valve from Beijing, China. And here you see the picture, which is a little bit similar to the Harmony, is on the horizon and being certainly assessed in China itself. And my valve from India, which looks a little bit like the Sapien, is also being evaluated. So these are the... So these are the valves likely to be on the horizon in future. Self-expanding valves, they've all got nitinol-based material. The valve stents, therefore, are able to conform to the outflow tract anatomy, and that's very important. And because they have less radial force compared with the balloon expandable ones, that is also likely to be acceptable for us in order to reduce the likelihood of problems related to the outflow tract expansion. Most of these self-expanding valves, as I say, are going on clinical trials or haven't really reached Europe yet, apart from the VENUSP-VALVE, which has got the CE approval. Potentially, these can be a single-stage procedures because there's no need for pre-stenting. And, of course, we're dealing with unobstructed regurgitant outflow tracts, which form the majority of our population. By single stage, I mean, when the companies are able to produce all the sizes and the lengths, then you could just balloon interrogate and then proceed, whereas up to recently, we've had to balloon interrogate as a separate procedure, identify the size of the valve, and then once the company produces that valve, then we bring the patient back. The VENUSP-VALVE, just briefly for your information, it's a self-expanding valve with a distal flare which is uncovered, and that's to allow flow and access into right and left pulmonary artery branches. The proximal flare, the right ventricular outflow tract, is covered, and there is a straight segment with gold markers or radiopaque markers, both where the valve is sutured and also at the distal junction with the distal flare. The valve leaflets are porcine pericardium, and then there's a controlled release handle for exposing the valve. The valve is available, and this central part is the diameter of the valve itself. That's a straight segment, and so they're available from 28 millimeters to 36 millimeters. The flares, both the distal and the proximal, are 10 millimeters larger, and then there are two lengths of each size available, 25 millimeters and 30 millimeters, and by that length, I mean it's a straight part of the valve, the length. The delivery system, the smaller ones, 28 and 30 millimeters, go through a 22 French, and the larger ones up to 36 millimeter go through a 24 French, although with Gore dry seal sheath making the procedure easier, we tend to put in, for the larger one, we put in a 26 French sheath. So, as I mentioned, apart from the regular angiography and measurements, we do balloon interrogation, and this is a very large outflow tract of about 34 millimeters with an indentation produced by the ASD sizing balloon. And here we used the largest valve, 36 millimeter VENUSP-VALVE, and you see the angiogram at the end showing a very good result, functioning, competent VENUSP-VALVE. There are some challenges, even with different tubular anatomies, and that's the angle of the outflow tract, and we have to make a decision about whether to deliver the valve through the left pulmonary artery or use the right pulmonary artery, but that's a technical decision that we make later on. And here are some steps where the valve is exposed in the left pulmonary artery, the distal flare, and gradually withdrawn back and then delivered completely. And you'll see it being released here. And then there's the final angiogram in this particular large valve showing a pulmonary angiogram that shows competent pulmonary valve. Here's a slightly more challenging anatomy with an aneurysmal outflow tract in which another 36 millimeter VENUSP-VALVE was implanted, positioned. We do regular angiograms in order to adjust the position, and that's the other nice thing about this in terms of not just conformability, but also pulling back to get it into the right position. And then once the angiography shows that the valve is in a decent position, then the rest of the valve is exposed. Here, there's the radiopaque marker of the covering sheath, which is then exposed, and the valve is released fully. And there's the final angiogram in the two different projections showing a competent valve, and a right ventricular angiogram showing, again, a really good outflow tract anatomy. Initially in our CE study, we excluded any patients with left pulmonary artery stenosis or left pulmonary artery stents because the carrot of the delivery system, it was almost impossible to get it through. But then when the dry seal sheath became available, here's this picture, a bit too bright really, but there's a dry seal sheath being passed through the stent here in the left pulmonary artery. And once the sheath is across the stent, then the VENUSP-VALVE carrot, it's very easy for it to pass through, and then we deploy the valve as in the normal standard procedure. And there's the final angiograms in the right ventricle and the pulmonary artery showing a good result, competent pulmonary valve, and a good flow into the left pulmonary artery as well. And we've had an unusual patient with a pseudoaneurysm of the right ventricular outflow tract, which we made models of and played around under fluoroscopy, where we put a muscular VSD device, Amplatzer muscular VSD device, in the neck of the aneurysm and tested a VENUSP-VALVE at the same time to deal with the pulmonary regurgitation. And once we tested it on the models, and it looked as if it could work, then of course the human himself was the key person to try it on. And here there's an angiogram within the aneurysm, quite a large aneurysm, and then with pulmonary regurgitation. And once the catheter was positioned in within the aneurysm, we then deployed a muscular VSD device and a VENUSP-VALVE at the same time. And again, that really worked and showed a very good result of both aneurysm dealt with and the pulmonary regurgitation dealt with. In the CE study, these were the inclusion criteria. Briefly, weight more than 30 kilograms, age range from 12 to 70 years, patients with moderate or severe pulmonary regurgitation, and MRI criteria that are reasonably standard in relation to the end diastolic volume, regurgitant fraction, and ejection fraction. And in the CE study, 83 patients were screened and 79 actually had successful VENUSP-VALVE implantation. You can see here the boss sitting in the front row with one of the CE enrolled patients. And of course, the photographer excluded me as much as he could. But I was helping Felix as well. Of the 79 patients, 1-year follow-up was completed in all of them. 69 patients had 2-year follow-up, and 64 have completed 3-year follow-up. Of course, some of the reduced numbers have been because of the COVID pandemic, which has really screwed things up in terms of follow-up as well as all the other areas around the world economically. Here's some basic data about the CE study patients. Mean age of 26 years, males almost equal split. Mean weight around 59 kilograms. Some of them had, not surprisingly being adults, had other diseases like diabetes, hypertension, coronary artery disease. But more importantly, if you look at this side, the distribution of the valve sizes, 84% of this CE study patients received a VENUSP-VALVE more than 30 millimeters. So that's quite important population to keep under consideration when it comes to our population of pulmonary regurgitation. 100% successful procedures, no mortality at 6 months or 1 year or up to 3 years in any of these patients. We were meticulous in obtaining adverse event data. So there was one distal flare thrombus noted at 3-year follow-up, which was treated with heparin and dual antiplatelets, and that resolved. And there's been no problems with that patient since then. One patient developed wide complex tachycardia acutely and resolved without sequelae. And then another patient who had right ventricular outflow tract ablation, and this patient had previous history of ventricular tachycardia, and subsequently ablation was undertaken as a prophylactic procedure. Then there is one other patient who developed a run of VT immediately after the procedure, which resolved. It was treated and then resolved overnight, and then has not been a problem after that. There was one guide wire perforation of the left lower lobe pulmonary artery. So now, because of the stiff wire we use, we do check the left, wherever the guide wire has been positioned, we check with a small angiogram to make sure that there is no perforation. In that particular patient, there was a prolonged stay in hospital because the perforation had not settled. There was one patient who had a non-STEMI myocardial infarction during follow-up, one who had contrast nephropathy, which resolved, and 7 other patients who had, these were not Germans, by the way, they're more from further east, sleep disorders. We noted it as an adverse event. Hemorrhoids, colonic polyps, anal bleeding, DVT, fever, and pleuritic chest pain. So we noted these, but obviously these are related to some of their other diseases and not entirely the pulmonary regurgitation or the VENUSP-VALVE. More importantly, at 6-month follow-up MRI scans, you see the most important progression or remodeling of the right ventricle, where the end diastolic volume has gone down from about 160 mean down to 116 mean, and all the others, end systolic volume has improved, ejection fraction pretty much unchanged. But very important, pulmonary regurgitant fraction from a mean of about 44% down to about 3%. So again, really good result. We were also meticulous in fluoroscopy in these patients and noting stent fractures or strut fractures. And Johannes had this classification published back in 2007, different types. All of the fractures that we noted on fluoroscopy in the CE study, there were 11 out of the 79, so about 14%, were at the right ventricular outflow tract end, which is the contractile part, and therefore not surprising. And they were either single or up to one patient who had 6 fractures. But most importantly, the valve function remained absolutely fine and intact. Having said we weren't doing any patients under 12, we've actually done them at Evelina. So we have around 11 patients who were less than 18 years of age, ranging from 10 to 18. valve diameters that were implanted in these children were between 28 to 36 millimeters, and over 90% of these valves were more than 30 millimeter diameter. So there's the scale of the problem that we are dealing with. And in those children, there were two complications. One in whom, my fault, jailed the right pulmonary artery, so we had to use a bioptome to pull the venous valve down, and that opened up the right pulmonary artery, which then needed stenting. It was stenosed already, and I thought we would deal with it in the future, but we had to deal with it there and then. And then there was one, and this is where all senior pediatric cardiologists will always blame their fellows. This was a fracture of a needle being done by a fellow who did the Z suture, and the needle broke inside the skin in the groin, and that required surgical removal. So that was the other complication, but that was purely the fellow's fault. Mean follow-up was 4 years. One of the 6 patients on fluoroscopy had evidence of a single strut fracture with no valve dysfunction. The others have been fine. 7 of these patients have had MRI scans, and again, the data is pretty similar to what we have seen from the CE study. And then I'll just briefly touch on the PULSTA valve, which is also porcine pericardial leaflets, knitted nitinol. This is delivered through a slightly smaller sheath, 18 to 20 French. Valve is flared at each end, but it's less than the venous and the Melody valves. It's 4 millimeters larger than the straight segment. The valve was available up to 28 millimeters before, but now it's available up to 32 millimeters. The first in-man implant was nearly over 6 years ago, and now the CE study has pretty much almost been completed. And here are some pictures from Ji Byom Kim in South Korea of the of the PULSTA valve being implanted. You see here, it's because of its shorter length and smaller flare, it does have a tendency to move on its own, so you have to be very careful, and I'll come back to this. You have to be very, very careful during the implantation, but you see here an excellent, competent PULSTA valve. Initial study in South Korea enrolled 25 patients, similar sort of mean age and similar end diastolic volumes, and with implantation of the PULSTA valve, reduction in the right ventricular end diastolic volume, there were no device-related adverse events acutely during the procedure. And now, of course, more patients have received this. So the 25 in Korea, and subsequently, the CE study has enrolled 56 patients so far in different centers. Post-market surveillance study in Korea, 157 patients. Outside of Korea, 78 patients have had compassionate use, and then 11 patients have had commercial use. So in total, in 10 countries, 23 centers, there are around 300 patients who've received the PULSTA valve. And in that group, there have been 6 patients in whom the valve has migrated. And again, Ji Byom Kim has provided me with these data and the pictures. And so the migration, in a way, it's not surprising in some of the complex anatomies. 2 patients had embolization into the right ventricular body. Surgical removal followed by surgical pulmonary valve replacement was performed. Both of these had that pyramidal shape. There was migration to the distal main pulmonary artery in one patient, and that was in Taiwan. And in that patient, the surgeons fixed the valve by suturing it into the pulmonary artery. And this was one with a reverse pyramidal shape. And then in 3 patients, the valve migrated to the right ventricular outflow tract, so a bit lower down, but not fully in the right ventricle. And again, in 1 patient, this was surgically fixed, and then in the other 2, the valve was removed surgically and replaced surgically. So to finish off, the issues really that we're faced with are the larger sheets, and that applies in particular to the VENUSP-VALVE and to some extent PULSTA valve, less so to the MELODY and SAPIEN. And therefore, the weight of the patient may have some influence on which valves are likely to be feasible. And that then is also influenced by the diameter of the native right ventricular outflow tract as to which valve you might want to use. But to finish off, self-expanding valves such as the VENUS-P valve, such as the PULSTA valve, really have expanded the horizons for us in dealing with large right ventricular outflow tracts. And in the suitable outflow tract morphologies, these can be implanted in up to, certainly the venous one can be implanted in up to 34 millimeter diameter outflow tract. And even pre-stenting cases such as in those that have MELODY or SAPIEN implants, with a straight venous, that can have an important role if you're really using big expanded stents. But the important thing is that it should be possible for us to match the valves to the right ventricular outflow tract anatomy. We have no idea about the longer-term durability of these valves, but for a venous valve, we have data up to 9 years now, and the valve's functioning very well. I'll stop there. Thank you very much.